Hi, Sarah. Elizabeth here. Happy
Hi,
New
Elizabeth.
Year. Good to see you.
Good to see you. Well, good to hear you, Elizabeth. Thank you for joining. Welcome. And welcome to everybody. As I've put in the chat, we'll just give things a few minutes, but we'll start in a few minutes. Okay, everyone. Well, I think we should start. My clock says 2 minutes past the hour, so I think let's get going and others can join as we go. So yeah, welcome everybody to Cochrane South Africa's Systematic Review Methods webinar series. We run these series monthly as part of our training in evidence-based healthcare and particularly focus on methods. And today I have the great pleasure of welcoming Dr. Natasha Gloeck. Tasha is a senior scientist in the Health Systems Research Unit at the MRC. She holds an MBCHB, a diploma in tropical medicine and health, an MSc in clinical epidemiology, and a postgraduate diploma in health economics. And she's currently pursuing a PhD in public health. And her special interests include evidence-based healthcare, primary healthcare, evidence synthesis, and evidence-informed decision-making and clinical practice guideline methodology. Tasha also helps coordinate the South African GRADE network and is co-lead of Goal 2 of the Evidence to Decision collaboration. So today, Dr. Gloeck is going to be giving us a presentation on grading of recommendations, assessment, development, and evaluation, so GRADE, for the typhoid conjugate vaccine uptake among children and adolescents. So just before I hand over to Tasha, I'd also like to welcome some of our colleagues. I'm trying to see who is here, but we've got some colleagues from the WHO that have joined. I see Thomas Sherin is joined. I'm not sure if Shanta Duta, Megan Carey, Judith Van Holten, and Farah Naz, who are maybe here now or will be joining. So very welcome to our colleagues from the WHO. Just a few admin things before I hand over to Tasha. If you could all please keep yourself mute during the presentation. Also, please feel free to type any questions or comments in the chat during the presentation. As they come to your mind, we will have some time for questions at the end of the presentation. And then finally, we will be recording. I think we already are recording the session, so please be aware of this. And the recording will be made available afterwards on Cochrane South Africa's website. Okay, I think with no further ado, welcome everybody, and thank you, Tasha, for your very kind presentation today.
Thanks, Sarah. Hi, everyone. As Sarah said, I'm Tasha. I'm from the Health Systems Research Unit. I would normally be greeting you from Cape Town, but I'm greeting you from Joburg today. I'm attending the National Health Technology Assessment Symposium. So exciting things happening in our country in terms of clinical practice guidelines and HTA. And today I'm going to be talking, as Sarah said, about GRADE. I'll use the TCV review, Cochrane review we completed in January this year as an example of some of the different grade steps and things one needs to think about. But it is a big review, so I've only focused on one outcome. And if you want to know more, you are welcome to contact me afterwards if you want to discuss more. I'm going to just turn my camera off for now, and then I'll turn it on again at the end. Right, just to note that the South African Medical Research Council recognizes the consequences of colonialism and apartheid in our country and is really working towards transformation within the different areas of the work that we do. I want to acknowledge the GRADE working group where many of these slides are from. I want to acknowledge my co-authors listed there, and then obviously the South African Medical Research Council as well as Cochrane South Africa. And then my disclosures, I am a member of the South African GRADE Network and a member of the Executive Expert Review Committee of the National Essential Medicines List. I'm also actually, which I forgot to put here, I'm on one of the working groups for the for NAGI for South Africa. So those are my disclosures. Right, so you'll see this is actually quite, these objectives are quite wide, so we'll see how far we get in the time that we have. But the aim is to explain the principles and methods of the GRADE approach in evaluating vaccine evidence using the typhoid conjugate vaccine example. And with that, at the same time, discuss how GRADE evidence profiles can inform WHO or other policy recommendations. I'll also talk a little bit about how we use GRADE for decision making, and then talk a little bit about the evidence gaps in typhoid vaccine research and the implications for policy and practice. So, sorry, I just want to make that small. So we obviously know that at the moment there's quite a lot of talk around vaccine disinformation. People are feeling like they don't trust vaccines. There's a lot of stuff coming out politically, whether we should be trusting vaccines. And it's important that we need to make sure that what we are putting out as researchers or guideline developers or policymakers is credible and trustworthy. So we'll just start with a case study. Your country is experiencing an increase in acute typhoid fever in children and adults, particularly in rural areas with limited access to clean water and sanitation. There's also increasing resistance to antibiotics due to empiric use. And health professionals are asking you to scale up typhoid vaccines. Particularly, they want to know if you can scale up typhoid conjugate vaccines, the newer ones. The Ministry of Health needs guidance on this, and they've approached your team for advice. And there's some results that are available for preventing acute typhoid fever that are shared with you. So first, you have a meta-analysis of 10 randomized controlled trials, which shows that, these are just hypothetical, by the way, typhoid conjugate vaccines reduce the risk of typhoid by 25%. Then you have one randomized controlled trial that says that they have no effect on typhoid fever. You've got an observational study showing that they reduce the risk by 40%. And then you've got an expert public health program manager who's been practicing for over 25 years, who says the non-conjugated vaccines are actually better than the conjugated vaccines for preventing typhoid. So as a researcher, what would you choose? You would probably think, okay, well, what is my best source of evidence here? Probably the meta-analysis. That's what we're told in terms of that hierarchy of evidence. However, what if I told you that for the meta-analysis, all the studies had a high risk of bias and there was significant heterogeneity? What if for the randomized control trial, I told you it was a very small sample size with wide confidence intervals, and for the observational study, it was a cohort, and the findings were consistent with previous observational studies? The expert public health manager who has been implementing the rollout of non-conjugated vaccines for the past 10 years and has vested interests in whether they're better than TCVs or not. That changes the picture. And the whole point of this is to illustrate that it's really important for us to assess the certainty of the evidence. So what does that actually mean? When we look at certainty of evidence compared to magnitude of effect is likelihood. So, for example, in the example there, the likelihood of rain is 80% chance of showers. The certainty of the evidence is how certain we are that a true effect lies on one side of a specific threshold or within a chosen range. So, in the example, the magnitude 80%, but we're 10% sure that we know what we're actually talking about. That's how certain we are in the evidence. So how do we actually assess the certainty of evidence? We need systematic, explicit approaches that help to facilitate critical appraisal, protect against errors, resolve disagreements, and communicate information. There's not actually any universally applied systems. There's a large number of risk of bias and other quality appraisal tools, like Cochrane's Risk of Bias 2 tool, the JBI appraisal tools, the Robbins I tool, and so on. And there's also many different grading systems for assessing bodies of evidence and facilitating guideline development. So the question is, which one do you use? One needs a single system to avoid confusion. It needs to be simple, explicit, and transparent, comprehensive, and actionable. At the moment, GRADE is widely accepted and applied. There's more than 120 organizations across 19 countries that have endorsed or are using GRADE. So that is why we are teaching or speaking about GRADE today. You can see some of the organizations on the side there. So beginning in the year 2000, the GRADE working group developed this single transparent system for grading the certainty of evidence and making decisions. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation Approach, and it's a way of understanding how confident we are in the results. It's transparent, as I've mentioned, and it also helps with developing and determining the strength of clinical practice recommendations. It offers a system of rating the certainty of the evidence in both systematic reviews and guidelines, and grading the strength of recommendation in guidelines. So you can see just the difference there. With systematic reviews, you generally looking just at how certain you are of the evidence, where guidelines take it a step further towards a strength of a recommendation. So just to put this into the context, the GRADE into the context of systematic reviews and guideline development, you've got your global or national decision-making body. They will highlight a question, a PICO question, which we'll go into briefly, and rate the importance of the outcomes. The systematic review team will extract outcomes across studies and pop that into an evidence profile with GradePro. They will then rate the quality of evidence for each outcome, rating down and rating up for different reasons, which I'll speak to, and then the overall quality of evidence across outcomes will be based on the lowest quality of critical outcomes. This then will go back to the decision-making body, who then can grade recommendations for or against, strong or conditional, and they balance a whole lot of effects that I'll also speak to in evidence to decision frameworks, and then formulate recommendations. So also important to note that GRADE looks at the certainty of evidence across outcomes. It doesn't assess how well an individual study was conducted, and it also doesn't look at how well a systematic review of intervention effectiveness has been conducted. It's really about looking across outcomes. And the steps of GRADE for conducting systematic reviews are as follows. You formulate the question, you select outcomes, patient-important outcomes, which is important for decision-making. You look at rating and ranking the outcomes for importance, extracting the outcomes, reviewing the evidence. And then the next step for the guideline process would be that the guideline panel uses then an evidence to decision framework to come to a recommendation. So this is our systematic review that we published in January this year on typhoid conjugate vaccines for preventing typhoid fever. And I'm going to use our PICO and, like I said, one of our outcomes just to illustrate the grade process. And then I'll also speak a little bit about some of the specific things one can think about when doing grade for vaccines. So firstly, you need to formulate a PICO question. You probably all know this, but the PICO stands for Population, Intervention, Comparator, and Outcome. And the reason that precise questions are central to grade is that it saves resources in developing new guidelines, it limits the scope of a project, it helps to specify the search strategy, it helps to guide data extraction, and it helps with formulating recommendations. For our PICO, we specified children and adults. Our intervention was any typhoid conjugate vaccine. Our comparators were no vaccine, placebo, typhoid inactive agents. So that was things like the meningococcal A vaccine or the Japanese encephalitis vaccine. So a vaccine not at all to do with typhoid. Then we also looked at on those top three, we actually grouped together because of how the data looked into a control group. And then we also looked at non-conjugated typhoid vaccines and other typhoid conjugate vaccines. So we wanted to see, is the efficacy similar across different typhoid conjugate vaccines? Our outcomes were acute typhoid fever, which we defined as a laboratory confirmed isolation of S. typhi, so blood cultures or stool sample. Also, we looked at all-cause mortality, adverse events, and serious adverse events, and we used the good clinical practice definitions for those. So that's the first step. The second step in grade is selecting the outcomes. It's a little bit different when the question comes from a guideline panel as opposed to you are just an author and you are interested in a topic. So for us, we as authors, we weren't doing it for a specific guideline, so we chose the outcomes we found to be the most critical after reading the literature. But if you're doing it as a panel, you would first determine what the perspective of the panel would be. So is it looking at programmatic health coverage, or is it looking at the individual clinical perspective? The outcomes should be important for people affected by the decision, not only those making the decision. And this is a really important and big move that there is towards patient-centered. There's always been patient-centered care, but really consulting with the people that are affected by decisions to find out what is important to them. Grade then rates the quality of evidence for each outcome separately. You may have a different source of evidence for different outcomes, or you may have the same source of evidence, so the same paper, but varying quality of evidence for the different outcomes. For example, let's say you have a systematic review where you are assessing pain, and you've got one of the outcomes is pain, but the other outcome is mortality. Mortality is quite black and white, someone died or not, whereas pain, depending on whether it was blinded or not, can be quite subjective. Then when choosing the important outcomes, it's important to identify the outcomes in advance. One shouldn't choose outcomes based on whether there are results or not. You should choose outcomes based on whether they are important, patient important or not. And when you describe the outcomes, you must make sure that they are very clearly described. So, for example, the measurement approach or the scale or the timing. Then the next step is looking at how we rate the importance of outcomes. So grade has this 9-point rating scale where 1 to 3 is not important, 4 to 6 is important, and 7 to 9 is critical. And only those outcomes that are considered critical should be the primary factors that influence a recommendation, and they should be used to determine the overall quality of evidence supporting the recommendation. Grade also recommends that you only choose 7 or fewer outcomes. This helps the decision process, helps to limit the size of the review, because otherwise the review can get very large and never finish. So it's important to just be pragmatic about the number of outcomes you choose. Then the systematic review team will extract the outcomes across the studies. So as I mentioned, for us, our outcomes in our review were acute typhoid fever, all-cause mortality, adverse events, and serious adverse events. And I'll speak to this later, but one of our challenges was actually how different papers and authors defined adverse events and serious adverse events, and how to decide when to include them in the meta-analysis or not. The fifth step is reviewing the evidence. Now, this is probably too small, and I'm really sorry if it is, but I thought this was an interesting result from our review. And the result, it was looking at typhoid conjugate vaccines compared to control in reducing acute typhoid fever. So the forest plot will tell you the magnitude of the effect, but it's not going to tell you how confident you are in the effect. So we can see that there's definitely favoring towards typhoid conjugate vaccines compared to control if you look at the bottom of the forest plot, but how certain are we in this? And that's where grade comes into interpreting the certainty of evidence. So you've got 4 levels ranging from very low to high quality. For high quality, we're very confident that the true effect lies close to that of the estimate of the effect. In other words, we're confident that what we're seeing on the forest plot is a representation of what is really happening. And then there's very low on the other side of the spectrum, which is where we have very little confidence in the estimate effect, and it really could actually be that any estimate effect could be true. So we're not confident in that at all. So how do we decide on the certainty? As I mentioned, there are these 4 levels. Randomized controlled trials start as high level, high certainty of evidence, and then can be rated down, which I'll speak to on the next slide. Observational studies generally start as a low certainty evidence. However, one of the exceptions to this is if a tool is used that allows the assessor to equate a non-randomized study with a randomized study, then it starts at high certainty. There's only one tool that does that at the moment, which is the Robbins tool. But so without the Robbins tool, the observational studies is initially assessed as low certainty because of the lack of randomization, which bears a risk of bias. Right. So when looking now at grade, and you've got your, let's say you've got your first outcome, which I'll speak to a little bit more on the next slide, but 5 things that can lower the quality of the evidence are risk of bias. So how well were the studies planned and executed? Inconsistency, are there differences in the study results we can't explain on the basis of the population or the intervention or the comparator or the outcome that were considered in the studies? Indirectness, so it's also known as applicability. How directly do the results relate to our question? So we summarize this as indirectness under the actual findings as they relate to our PICO question. We can also call it generalizability or external validity of the findings. Then imprecision, is the effect precise, or is there substantial random error whereby the upper versus the lower boundary of the confidence interval would lead to a different course of action? And then other is usually looking at, is there any sign of publication bias? It is difficult to determine because often there's not enough studies for us to actually judge whether there may be publication bias, but that is a consideration. Then there's also some factors that can increase quality, although it is important to note that if you have an observational study and you have rated down for anything, so risk of bias or inconsistency or indirectness or imprecision or other, you cannot rate up as well. So you can only rate down or rate up. You cannot do both. So the 3 factors that increase quality are a large magnitude of effect. So an example of this would be before this treatment, or this vaccine, everyone used to die, but now with the vaccine available, everyone does well. One of the examples that is commonly used is parachutes. The US Parachutes Association said in 2007 there were 821 injuries and 18 deaths out of 2.2 million jumps, which is a 0.00001% risk of dying compared to close to 100% with no parachute. It's a very large effect. It's a simple example, but I think it's a good illustration. Then opposing bias or confounding. So there may be an exaggeration of the treatment effect we observe. So maybe it's confounded by the health status of the people. We don't know to what extent the observed effect is due to the intervention itself or due to people in the intervention group being healthier. And then finally, a dose response gradient. So that's where there's a relationship between the frequency and magnitude of an outcome related to the degree of exposure to an intervention. So for example, with an increasing dose of medication, maybe you will get increasing frequency of adverse events. So back to the review and looking at the same example, I'm going to just take you through how we graded this example. Firstly, we looked at the risk of bias. And for us, we had a look at the first study, Mitra 2016, which was a cluster randomized controlled trial, which had some concerns of bias in domain 2, as well as GIN 2017, which was a human challenge study, which also had high risk of bias in domains 2 and 3. And because they held almost a quarter of the weight of the study, of the results, we decided to rate down for this, but that is a judgment call. So we rated down for risk of bias. Then inconsistency, what one's looking at is you can look at how the confidence intervals overlap, and you can also look at the chi-squared test, the p-value, and the I-squared. What grade recommends is if there is unexplained inconsistency, you should rate down. So we knew why there was inconsistency. It was driven by GIN 2017, that study. But for us, the fact that it was a human challenge study was not enough of an explanation to not rate down. So we did also rate down for heterogeneity or inconsistency, but others may not have. And an important consideration when developing a guideline is that this specifically may not be enough to rate down. So we did it in the context of a systematic review, but for a guideline, it may be enough to say that all the studies are in the same direction. It doesn't necessarily reduce our confidence in the result. Then for indirectness, the question was, is the evidence applicable enough to our PICO? And we thought, yes, it was. In terms of imprecision can be caused by a small sample size or a small number of events. So it helps to look at the absolute numbers, which I've added there. So this also may differ when making judgments for a systematic review compared to a guideline. We didn't rate down for imprecision because it was quite a nice tight confidence interval. But with guidelines, they also take into account values and preferences as well as thresholds that often represent a basis for a management decision. And systematic reviews often use the optimal information size, which we can talk about more if anyone is interested. But the general rule of thumb for grade is that dichotomous outcomes, there need to be at least 300 outcome events and continuous outcomes, at least 400 participants for it to be precise. And then finally, for publication bias, as I mentioned, there are challenges. If you have 10 or more studies, you can do a funnel plot, and that helps you get an idea of whether there's any publication bias, but we didn't do that. We only had the 6 studies. So this is then the summary of findings table. And again, I apologize for it being a bit small. I suppose it's only so big a slide can be. So there's our outcome that we've been talking about, acute typhoid fever. You can see the absolute anticipated effects. You can see the relative effects, which was the same as the forest plot, the number of participants and randomized controlled trials, the certainty of the evidence, which, as I mentioned, we downgraded for risk of bias and inconsistency, which we justified there. So grade always, even if you make a judgment that others disagree with it, as long as they can see why you made the judgment, it's helpful. And the conclusion that we came to for the review was that TCVs may result, and the may result is due to that low certainty evidence, and that's the language, the grade language, but may result in a large reduction in acute typhoid fever when compared to control. Out of interest, we looked, there was quite a wide range. So we had follow-up ranging from 1 month to 4 years. So we actually did a subgroup analysis, if you want to go and have a look in the paper, just to see, is the effect of the vaccine waning over time? And what the subgroup analysis showed that it's all between, we'd looked at before 12 months, 12 to 24 months, and more than 24 months, and even more than 24 months. And that specific study was one that was measuring vaccine efficacy up to 4 years, still showed that typhoid was more effective or resulted in a large reduction in typhoid fever when compared to control. So even with the time lapse. So as I've said, grade summarizes the rating of the quality of evidence across selected outcomes. When it comes to grade for recommendations, we have grade specifically, because that's what we're speaking about today, has evidence to decision framework, but there are others. So there's a WHO integrate framework and others. But essentially, it's about providing an explicit structured approach to decision making, making sure that there's transparency in the decision making. And also importantly, it doesn't prevent disagreements. So it's not about making sure that everyone agrees. It's about making judgments. It's about getting the experts in the field who are in the best position to make these judgments, looking at the evidence. And it's also about getting disagreements to be explored and built on and documented so that people can understand how the decision was made. So the whole idea with the evidence to decision framework is away from this idea of you've got a problem, and then you've got a decision, and no one knows how that decision was made or what was taken into account, to considering all these different important things like equity, feasibility. What are the benefits and the harms? What is the balance of the effects? What is the resource use? Is it acceptable to people, and is it important to people? Do they value this? So within that, there's some key evidence that decision makers need. There's the balance of benefits and harms, which you will get from your systematic review, like the one we did. There's values and preferences. There's looking at costs or resources and cost effectiveness. Is it effective, acceptable? Are there any equity issues that bringing in this intervention may help or may actually make worse? And then is it feasible in the context in which you are making this decision? So the move then is away from that black box to the systematic, transparent assessment, where you've got your problem, you've got your criteria, which are listed there. You've got your research evidence, which may not be the same research evidence for each criteria. Then you have additional considerations. So maybe there's something from a programmatic side that they can input into feasibility or into cost effectiveness or whatever resources required. And then you've got the panel's judgments, and you land up with a decision. So just to note, you should present the best available evidence for each option. So for example, as I said, this systematic review would fit well into the benefits and harms. Maybe you would look at utility value studies for values and preferences. You would maybe look at doing some modeling or economic analyses for your cost effectiveness. And then perhaps looking at qualitative reviews or studies for equity, acceptability, and feasibility. Then, as I mentioned, there's also space for other important information. As I said, I know one of the discussions we had within our NAGI was we brought in the program for the vaccine we were discussing and heard from them what do we need to consider in terms of how is this actually feasible in rolling out. And then the panel's judgments are recorded, which then leads to recommendation. So essentially, you have your health effects and you have your contextual factors that all come together to make this recommendation. And then the recommendation once the panel is making it, they need to decide, are they for or against the intervention? Is it a strong recommendation, which I'll speak to just now, or conditional? It should be consensus decision making, not one person making a decision, but the whole team, which should include various stakeholders, including people affected by the illness, so patients and the public. So the strength of a recommendation is around whether it's a strong recommendation. It means there's confidence that the desirable effect clearly outweighs the undesirable effects. A conditional recommendation is where the group concludes that the desirable effects probably outweigh the undesirable effects, or vice versa, or are closely balanced, but they're not confident that about these trade-offs in all situations. So at implementation, monitoring and evaluation is needed to address these uncertainties. And this is also where it's really important to consider contextualization, not duplication. So, countries, if, for example, if it's a WHO guideline, countries can take that on, but then contextualize the ETD to their own situation so as to not duplicate the work, but to build upon it to work within their own context. This is just a quick overview of this amazing paper by Holger and team at the Grade Working Group, looking at the evidence ecosystem of health decision making and how all these different ways that we make decisions all actually follow a similar process in getting to implementation. So just to flag it, if you're interested, go and read it. I won't go into it now, but it's quite a nice paper just to think about how implementation in whichever context, whether it's vaccines or whether it's coverage decisions or guidelines, whatever, are being made. Then, just to finish off my last couple slides, I wanted to talk about some vaccine-specific grade considerations, just because I used the typhoid conjugate vaccine review as an example. So firstly, with risk of bias, there may be blinding challenges. So whilst trials often do what they can to prevent participants and investigators knowing which group they're in, they may recognize the vaccine due to local reactions, for example, an injection site pain, which could potentially unblind the study. That's something one can think about. There could be differential loss to follow-up. So you could have long-term follow-up that differs per group, especially when there's multiple doses of a vaccine required. There could be outcome assessment bias. So surveillance for infection or disease may differ between vaccinated and unvaccinated groups. And then funding sources. Vaccine trials are frequently industry sponsored. So it's important to just keep in mind that there may be selective reporting and make sure that that's not a factor. Then inconsistency. So first is obviously thinking about heterogeneity across settings. The efficacy may differ by age, HIV status, endemicity, prior immunity. There may be different vaccine formulations or schedules, so variations in valency or dose spacing. You could think about differences in disease epidemiology. Is it an outbreak or a routine immunization where the trial was done? What is the baseline disease incidence? And then also that adverse events, as I mentioned earlier, are often defined and reported differently, and that can also bring in inconsistency. Then indirectness. So especially with vaccine research, there's often surrogate outcomes that are used. So for example, immunogenicity, antibody titers are often used instead of disease prevention, which are indirect measures of clinical protection. Then looking at herd immunity, so the indirect population effects may be estimated rather than directly measured. That could possibly bring in some indirectness. There's also indirectness could happen because of extrapolation across populations. So evidence from one age group or region or setting or epidemiological context may be applied elsewhere. So for example, applying findings from a high income setting into a low middle income setting. That's where contextualization is important, but it's important to consider that for indirectness. And then variant evolution. So for those pathogens, pathogen evolving diseases, antigenic drift introduces indirectness if the evidence is based on earlier strains. In terms of imprecision, it's important to think about rare events. So for our review, for example, we found that serious adverse events and mortality was uncommon. So this meant we had these wide confidence intervals, but we actually didn't grade down because grade recommends that with rare events, you don't actually necessarily need to grade down for these wide confidence intervals. Then for event-driven outcomes, it's similar to rare events, but the low incidence can lead to sparse data. One needs to balance the small risks and the small absolute benefits, especially safety outcomes in low incidence settings. And then also one needs to consider the duration of follow-up. So a short trial may miss long-term warnings or delayed adverse events. Finally, for publication bias, one needs to consider, as I mentioned, in risk of bias, industry sponsorship. Negative or inconclusive data may remain unpublished. Then one needs to think about was regulatory data asked for? There may be unpublished trial data that that should have been requested from, for example, the FDA. And then one needs to consider whether there was any media or political pressure. So, for example, in pandemics, I mean, we saw it with COVID, early release of partial results could potentially skew perceived evidence. So that's important to consider. In terms of what is missing, or what we found was missing, and I'm sure there are many others on this who could point out others. So these are just the ones we found. We found that it would be important to know what are the different impacts of TCVs across demographic and socioeconomic groups. Our findings indicated significant equity-related implications for research on TCVs. Despite the assurance of reducing typhoid fever incidence, the current evidence base doesn't fully address the different impacts across these groups, and future studies should prioritize inclusivity by ensuring diverse participant representation that reflects the global burden of typhoid, particularly in low-resource settings. In terms of evaluating the accessibility and acceptability of TCVs among different populations, it would be good to include barriers faced by marginalized communities in accessing vaccines. This would help identify disparities in coverage and effectiveness and guide tailored interventions that improve equity in vaccine distribution and administration. In terms of the implications of integrating TCVs into national immunization programs, particularly in countries with varying health infrastructure capabilities, it would be good to know how or research could explore how TCV implementation strategies can be adapted to local contexts to ensure equitable access to effectiveness, including collaborating with local health authorities and communities to develop culturally and economically appropriate vaccine strategies that uphold equity and justice, and then obviously values and preferences of the target population. And many of these may have been answered already since we've published, and also will be looked for if one's doing the evidence to decision process. This sort of evidence is what would be looked for. So that was a lot of information in a nutshell on GRADE and briefly on typhoid conjugate vaccines. Like I said, the review is large, so I would be very happy to, if anyone wants to discuss it specifically, I would be very happy to engage offline the whole review. But yeah, that's where we are. Thank you.
Oh, wonderful. Thanks so much, Tessa. Really, really, absolutely fascinating. And just such a great presentation, taking us through grade and sharing some of the specifics when it comes to the kind of vaccine space. So really, really fascinating. And I'm struck by how different the issues are, obviously, depending on the kind of the particular content where one have to apply the methods. So yeah, really, really thank you. Yeah, so please, I'm going to open it up the floor. Any questions, any comments, please feel free to raise your hand or to write anything in the chat. Alternatively, as Tasha indicated, you can also engage with her offline. But yes, I see we've got great 2 questions or 2 hands. Annalisa, do you want to go? And then Kim, please go ahead. If you want to
Yeah,
unmute yourselves.
thanks so much. Can you hear me? Because I was struggling with sound.
Yeah,
Perfect.
Yeah, perfectly. Just want to extend my appreciation to you, Tasha, for presenting, especially since you're attending a conference in Joburg. And I wanted to chair this meeting, but I'm attending the conference right here next door, so I didn't want to make a noise for people. So Sarah stepped in. But I just have a comment and a question. My comment is that I really loved it when you said that, making recommendations should involve a diverse group of stakeholders, particularly not only, scientists, researchers, or people who produce evidence, but it should also include those most impacted by the illness. So that's truly the heart of effective policy making. Thank you for making that point. And I wanted to ask, I know that you said the review doesn't address the impact of TCVs across, various groups like demographics and socioeconomic groups. But I wanted to find out if your review, because I just went through it, does it include evidence around the efficacy or effects of TCV booster doses, specifically among children, and how does that evidence compare to, the initial vaccination series? I didn't get that. Thank you so much.
Thanks, Annalisa. We didn't actually look at booster doses. We just did that subgroup analysis where we looked at the efficacy of the vaccine, the initial vaccine. So there's one paper that came out quite recently by Patel, I think it's 2024, that they updated it, where they were seeing signs of efficacy up to 4 years post-vaccination, but we didn't look at specifically at the boosters. I think that would be a good question for the update or for the next iteration of the review.
Yeah. Okay. Thanks a lot, Tasha. Thanks for that.
Okay. I see another hand. Shall we?
Yeah, Kim, do you want to unmute yourself?
Hi, thanks, Sarah, and thanks, Tasha, for the very informative presentations. I love praise. My question, just maybe a silly question. I don't know. But I'm just wondering if it's possible or if it works, if the reviewers or the review team can take into consideration or can take raise consideration into the reviews at early stage. For example, is during the formulates, the review questions. So the reason I'm asking for this, because if we look at the indirectness, and then, for example, if now we end up, we have indirectness in race, and then some of other things like high risk of bias and so on, and we end up with the uncertainty of the evidence, meaning, the recommendation is not really valid. Yeah. Whatever we can, recommend this. So if the outcome of the reviews with the high level or with the low certainty of evidence would mean that it's worth it to do the reviews. We end up like we took 6 months to a year to do a reviews, and then we end up, okay, we cannot, recommend this,
Yeah.
because the evidence very low certainty. So how will you, Michael,
Yeah.
thank you.
Thanks, Kim. I hear you. Yeah, I mean, this review took 18 months, I think. Yeah. So, I mean, look, you can't go into a review thinking that you're not going to do it just if you think that the certainty of the evidence will be low. There's always value in doing a review. So even if you have for an outcome a low certainty of evidence, that in itself is a trigger to stimulate further research and say, look, we don't know enough about this. We need more primary research. So I think even though, it may not lead to a recommendation, it may lead to a recommendation of more research is required as opposed to an evidence recommendation of, we can use this intervention. So I think there is value, even if it's low certainty. For me, I think there's value. Luckily, with this review, we had mostly low to moderate evidence. But yeah, I hear you. I mean, it kind of feels like, what was the point? But it is important anyway, I think. I don't know. I don't know. Does that answer your question, Kim?
I I agree with you, but I'm also, I'm I have done quite a number of, so I'm involved in systematic reviews a lot. It's often how I feel when, our finding, our evidence, and we say, I don't, that's,
Yeah, I agree. And, I think what you were saying earlier also raised a good, important point, was that if we are looking at, and maybe it also ties in with what Annalisa said, if we're looking at including our stakeholders right at the beginning of the process, including the patients and the public and the people that are affected by the condition right at the start, when you're actually formulating your PICO, then at least you are answering a question that is valuable to people, and it's going to make a difference. Whether or not it ends up high or low or moderate or low, very low certainty evidence, it still means you've got that now that you can work on, and you know that it's important and valuable.
thanks.
Yeah, thanks. Oh, sorry.
I know, go ahead. Do you want
Yes,
to
I was
add to
gonna
that?
say, I wanted to add to what Tasha was saying regarding Kim's comment that reviews with low to moderate certainty of evidence can yield, enormous valuable insights, and they can inform, health decision making as well. When you consider different contexts, you can throw in the fact that there's limitations of available data, and it just drives to more research. So it's important, very, very important. Even if there was just low certainty of evidence in all our outcomes, that's still a valuable result. Thanks a lot. Yeah.
And I think we've got another hand. Thomas, please go ahead. If you want to unmute yourself.
Yeah, I have unmuted, and thanks a lot for the opportunity. Yeah, I just wanted to point out that, sometimes even when you have low certainty of evidence or very low certainty of evidence, you can still make recommendations. But those
Exactly.
recommendations would be conditional. For example, for dengue, we knew that the certainty of evidence was very high if the subject was seropositive for dengue uh, at the time of vaccination. Whereas if they were seronegative, then there was this risk of, maybe enhanced disease or something. So the conditional recommendation then that was made was to adjust the age of vaccination to a time period when you knew that the seroprevalence, the baseline seroprevalence would be high. So you avoid the risks, and at the same time, you provide protection to those who are seropositive. So you target those people who you are fairly certain would benefit from the intervention. So you can make or adjust your recommendations, make them conditional to a certain number of factors that then still allows you to benefit from the vaccine for those subpopulations that are likely to benefit, while avoiding any risk or potential risk to those who may not.
Yeah, that's a really great point. Thanks, Thomas. A good example of that is also something like the pneumococcal conjugate vaccine, where we know that the pneumococcus disproportionately affects people with HIV, specifically those that are, have low CD4 counts. So one can target a specific population within your recommendation once you have that research evidence. Yeah, thanks for that.
Thanks, Tasha and Thomas, for really great input. So I think there was another hand, or it was maybe put down. Yeah, I see we've got also a question from Helen about the recording and the slides, and we'll definitely share the recording. And if Tasha's happy to share the slides, we can share this with you all. So yeah, absolutely. Yeah. Any final questions, comments, thoughts here?
Hi, Sarah. Thanks a lot. Oh, there's a question. Sorry, because I was gonna make a final comment, but there's someone.
Okay. Well, let's go Theodore and then you, Anna, to make a final comment. Theodore, yeah, please.
Thanks for the presentation, Tasha. I'm Theodore from the HSRC in Cape Town. I don't know if it's related, but periodically schools do send out forms for vaccination, and then sometimes the parents are not informed well enough to give consent for the vaccination to occur. So in your opinion, is there a better way that the health authorities or the respective stakeholders can approach this vaccination process?
Oh, that's a great question. And Sarah actually did quite a nice systematic Cochrane review on that, looking at vaccine hesitancy in parents. But it's definitely not my area of expertise, but I do know how important health promotion is, and that we are not necessarily doing the best work that we can when it comes to health promotion. I think we need to be doing more in terms of getting evidence out there in a way that people can understand, whether it's through graphics or infographics, or, and it needs to be available on the media, online, where people can access it. Because if we are just at the last minute sending a form home. I mean, I've received those forms because I have primary school children, and I'm grateful that I understand, but I can also understand that people may be nervous because they don't know enough. So I think it's really about focusing on health promotion, and I think that's also just a big push that we're going to have to do moving towards NHI as well. Health promotion is going to be key. But yeah, it's not my area of expertise, so specific recommendations I wouldn't know.
Thanks, Tasha. And yeah, thanks, Theodore, for the really great question. And as Tasha said, we've done a qualitative evidence synthesis on some of these issues that you might want to have a look at, self-promotion of work here, but looking at, how we can try to engage parents more and the public more around vaccination issues. So it's not enough to just be doing the evidence sort of and the reviews, but how we can translate it. So yeah, would be very interested in discussing more with you. Yeah, so I think we've come to the end. Annalisa, I don't know if did you want to make a final comment? Would you like to close us off?
Yeah, no, I just wanted to send my appreciation to Tasha. I know this was it's very tight, tight, things are tight here, this side, but she set her time apart. She
All
set her
good.
time apart, and she presented to us, and we planned this 2 months ago, and she knows why. I'm not gonna divulge, here. She knows why I've been pushing for this, and I see two of my WHO colleagues, Megan and Thomas. Thanks for attending, and see you guys soon. Thanks a lot, Sarah, for holding the fort in my absence, because I really wanted to facilitate this one, to chair this one. Thanks a lot.
Absolutely. And yes, as Anna and Tasha said, as we speak, they are in the evidence-based world at a conference and engaging with the decision makers. So yeah, I really appreciate giving up the time to also come and share with us. So yeah, really thanks to everyone for joining, and many, many thanks, Tasha. Just a fantastic piece of work that you've done. And yeah, all the best with the conference that you're at. And we hope to see more reviews like this coming from you. So yeah.
We'll see. I'm still recovering.
Yeah.
Please work on the TCV booster updates, Tasha, because yeah.
Noted.
Yeah. Thanks.
Thank you for having
Thank you,
me.
everyone.
Yeah,
And we
thanks.
hope to see you at our next webinar. Thanks a lot,
Bye.
everyone.
Bye,
Take care.
guys.
Bye.
Bye.